So we're just going to spend a couple minutes here. We're trying to balance a lot of new faces in the room with some of the quality improvement tool teaching that we did very early on in our collaborative in years 1 and 2 when we were all new and trying to figure out who knew what about improvement. So we're going to talk a little bit about a tool that is pretty easy, and again, it'll be hands-on. And I'll start out by introducing the tool, and then we'll all get together and use that tool as a team. So we're going to talk about key driver diagrams. So if you don't mind, I just want to take the pulse check in the room. Can you raise your hand if you've ever used a key driver diagram in your quality improvement journey at your institution? Who has not seen or heard of a key driver diagram, or maybe hasn't at least used it? Okay, a couple hands. Okay, perfect. All right. So in the world of quality improvement, there's a variety of ways to get to, an idea of what you want to improve, how to focus on a problem, and then kind of put a theory together in terms of what do we think is causing this problem, and then ultimately trying to match what we might do about that problem. And that's where a key driver diagram is a tool. So basically, we want to set ourselves up for success by clearly, visually creating something that a team can get behind and say, what are we trying to do here? I mean, how many times have you been in a room where, the problem is not really the problem, that everybody spends a lot of time, whack-a-mole, putting patches on things to improve things, when you never really spent the time to really understand what it is you're trying to work on and then logically follow it. So our first step is to set an aim or a goal, all right? So for instance, we want to reduce chest x-rays, okay? So as an example. And then what you want to do then is the next step is try to figure out, and these are theories, right? There's a lot of quality improvement is about theories. What do you think is causing the problem? And this is where I think a lot, at least in my journey through quality improvement education, where I find it fascinating because people spend a lot of time jumping through the hoops here, getting to the fixes before they really spend time understanding if the problem is clearly identified and what do you think driving that, okay? So that's why a visual tool is so helpful. So then there might be other drivers behind those primary drivers that may then be lending to that behavior. So before you can actually get to the potential interventions, it does take at least a 3-layer approach, we think, and other experts in quality improvement, nationally and internationally have come up with these easy ideas to think about. So then we get to the change ideas. So my introduction is going to be an introduction, and I'm going to show you a piece of a toolkit. Piece of a key driver diagram. So it starts with a SMART goal. Everybody remember what a SMART goal is? It's it's got specific, it's measurable, it's achievable, it's relevant to what you're doing, and it's time bound. So you'll notice that we have this first box in our key driver diagram to write that down. So I want to reduce chest x-rays by 25% or 5% or whatever towards our goal by January 2023. Okay, so that's an achievable target, and you decide at your sites how that's how you're going to set that. Maybe you're the site that's or the individual that's 76% utilization, and you want getting down to 17% is not feasible. What's achievable? So a SMART goal takes all of those things into consideration. Then these are followed by the primary drivers. What do you think is really behind this? What's the, that's why when we worked on some of our modules, some of you were on task force and we really got under the hood of what's driving this? What do you think our key concerns are between this behavior that we're seeing that we're trying to modify? And that's where those drivers come in. And then our secondary drivers. What are the intrinsic factors, that, are they systemic? Are they, because somebody else is pushing you? Or is it you yourself? Is it that I don't know? Is there education? So there's a lot of different things. So that's why it takes a team, and a multidisciplinary team for quality improvement is super important for that reason. You really want perspectives. Like for instance, when I, did a quality improvement project in my own ED, we made sure we had all the relevant stakeholders from nursing to pharmacy to whatever, because I'm not seeing the whole problem by myself as the ED provider. There's other people around me who have a stake in this, in addition to patients. So anyway, so having all those things. So then we get to the change ideas, okay? So now once we kind of get through our theories of focusing in on our problem, what do we think that's driving, and then getting to the change ideas. So we're going to start with one arm and just go through a chest x-ray example. And we're going to go through just a couple, helping you get some primary and secondary drivers on the board here. And then we really want to kind of think about what are some, and organically ask you in the audience to help us think about, now that you've heard some ideas, what are some activities and change ideas we can take and share with each other to take us to the next level of performance in 2023 when it's going to matter. So I already gave you the SMART goals. We want to reduce chest x-rays in children with known diagnoses of asthma, bronchiolitis, and croup by X%, depending on your site or your individual, by Y date, okay? And maybe you want to do this a couple times in iterations. Well, let's take a little chunk and improve this time, and then we'll reset it and do it again. So you told us, and some of the people in the room don't know this, but we worked very hard on the toolkits, and one of the ways we did that was we used the pediatric committee, which is composed of both pediatric emergency medicine providers and general EM physicians, to tell us, what do you think is the most important driver or a key driver? And a lot of us said, we're worried we're going to miss a diagnosis for which the management would be different, okay? We've got a child with one of these diagnoses, or it's in the differential, and we're worried that we're going to miss that kid with pneumonia that we should have treated with antibiotics or whatever. So this was a big driver, so we put it in here. How about secondary drivers? Can anybody give me any examples of secondary drivers that might be feeding this particular one? Anybody? Spitball.
You said the first, that's right.
Thank you. Did everybody hear that? External influences, okay? So PCP, outside of writers. Anybody else? Perfect. Anybody else? Excellent. Okay, so there it is. Kind of like that game show, right? Referring in patient providers, right? So you've got external forces, outsiders telling you, I'm sending the patient in, I'd like them to get a chest x-ray before you've ever laid eyes on the patient. The other is internal. And then the other thing is that in a lot of places, right, you don't realize this, but radiologists, they dictate, the fuzziness. Can't rule out pneumonia, or, the perihilar, blah, 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 and is it pneumonia? I don't know. Is it not pneumonia? It could be pneumonia. So there isn't a standard for interpretation of chest x-rays for which radiologists have to sit there and tell you yes or no. They give you the hedge, that joke. So anyway, these were the ones we thought of too. So I'm glad that sort of organically came about. So now the harder part, right? And this is like all politics are local. Your change ideas might be local, because Children's Hospital told us we had a default thing that chest x-ray. We just unclicked it, okay? So that's a very unique thing to CHOM. Not all of us have hardwired, defaults for chest x-ray in our EHR. We might not even have an order set for something like this. So I'm going to take a few minutes here. First of all, I want to ask, does anybody have any questions about how to use this? Pretty easy, huh? It's nice, and it's meant to be used in a team setting with your QI team. Okay, so let's just walk through this just to kind of spitball this. I want to make sure I'm on time here. So let's go through the parent-patient expectations as a leaderboard to I'm gonna miss a pneumonia. Parents worried, that they're gonna miss a pneumonia. You're gonna mistreat their child. What are some things you can do in the ED? Maybe a small little experiments or change ideas, interventions that you could do to try to get at that. Anybody? Spitball. What can we do? Sorry?
Education, what a provider might look for, besides pneumonia versus what the patient has.
Perfect. Like, maybe there's a thing in the room for patient-parent expectations, or some, I think, Andrea, I think you can talk to us a little bit about how you might have done that at your site, or sometimes people have like little TV screens, hey, your child's here for, suspected pneumonia. These are the things we think about. So things can be happening in your ED, not necessarily that your provider has to do, but that can facilitate that education. So that's awesome. Anything else come to mind? We can influence patient-parent expectations. So
that sounds like a great shared decision-making tool that they use.
I was just going to say,
reading all of your intervention templates, guys. So we know you guys have good intervention.
Yeah, we're using the chest X-ray example, but this could be head injury, right? And so somebody, you know, several of our sites use shared decision-making tools. There are some nationally acceptable. And, you know, there are examples of this. So you can actually use a shared decision-making tool that, you know, either could be online or sitting on a board in a room or something like that. So, okay. So I'm going to stop there. Anybody else have any questions at all? My only other question to you is, I'm going to back up 1 second because I got just a couple seconds. Because some people have been working on referring inpatient provider push or external, and that seems to be a touch point for a couple of places. Anybody have any ideas for how to mitigate that? We heard a couple this morning throughout the day. Mitigating inpatient and outpatient. Is Sarah Chackle in here? Sarah, you had a question about this, so I'm just kind of curious if you have thought about that at your site.
I'm sorry,
Yeah, about like how to mitigate, like if somebody is external to you, pushing, like your inpatient providers might push you to do an X-ray, or your inpatient or your external people rifling in.
Yeah, I mean, everybody gets these referrals in urgent care or pediatricians, and really try to set expectations. So tell them that we're going to do anything, we're happy to see them.
And then any
tell our inpatient teams, you're welcome to come to order it. You also are an ethics.
Yeah. And I think we heard in some of the examples, you guys have, I think ECS, if you can speak to this, you have like a window into like sometimes external, and Rob Nolan, you too, external relationships with feeders to your system and how you might do that. Can one of you speak to that? Like, is there an advisory group to the community or something, or how would you like set, you know, try to mitigate that blue box?
One of the things that we did, was to set that as a vendor for outpatient docs as well. And so we did some education with the outpatient docs, and we were able to grab some data and show some. There was one clinic in particular that was an outlier for both pediatric MCTs as well as chest X-rays. Most of the strategies that you guys are using unblinded. It's amazing how much peer shading can do. And that really brought home the message of who wasn't happy to take care of kids. Please do not tell them that you need to do certain things. And if they do, we instruct our providers to, at that moment, call up the provider and say, did you really send this patient? And the patient and the family say they're here for a chest X-ray. And 9 times out of 10, oh, no, we didn't look. We said maybe they would sort of. But that's another little soft reminder that, you know, please, we'll care for your patient population, but don't tell them what we're going to do.
Yeah.
Michelle just mentioned on the inpatient side, so we'll get those requests to get a chest X-ray, like et cetera. We just went through an iteration, particularly for bronchiolitis, and building a clinical pathway that encompasses the continuum of care, so from the ED to admission or discharge from the ED. So you mentioned it before, having stakeholders from all of the environments at the table, building that pathway was really, really helpful. I realize that doesn't apply to every setting, but including the inpatient providers in that conversation to get consensus before we, you know, instead of fighting that battle every moment each time is really helpful.
And I think we heard that too from Chom. I think, Christian, you mentioned it too, is that once the inpatient providers realized they had a problem too, it was through that process that you had that conversation, and then suddenly you got a friend in your improvement journey. Okay, I'll quit there. And if anybody wants to talk more about key driver diagrams, I'm here. And there's a quick, I'm just going to plug the Improvement Institute for Healthcare Improvement, IHI. If you Google IHI key driver diagrams, you'll see immediately, it'll take you to like a less than 2-minute video done by some experts that's outstanding, that you could even use as an intervention for your, you know, or as a team to try to like get them to focus on the problems. Thank you.